feasibility study in a porcine model for evaluation of transcardiac access routes by the Hamburg group.
Dear Chairman, ladies and gentlemen, thank you for the opportunity to present our animal experimental data. Of course, gold standard for type A dissection is still open surgery, but the outcomes after surgical treatment in octogenarians is not so good. So there are many postoperative complications, and also the in-hospital mortality rate is quite high. Also for patients with previous cardiac surgery, there might be problems. They've got more TIA and stroke and also a higher in-hospital mortality. So our hypothesis is that acute type A dissection patients with older age, severe comorbidities, or previous cardiac surgery that are unfit for open surgery might benefit from less invasive therapy. The standard approach is the transfemoral retrograde approach, but there are also limitations in the transfemoral access. First, the distance to the ascending aorta and the aortic arch is quite long. Further problem might be the tortuosity and the kinking of the femoral and iliac access vessels. Also, the hemodynamic forces in the ascending aorta are quite different from the descending part of the aorta. Then you have to introduce a stiff guide wire through the aortic valve into the left ventricle and have the risk of myocardial perforation. And you have a difficult true lumen access from the retrograde approach in case of dissection. Also, the apposition of the stent graft might be a problem. So why should we use the transcardiac approach? The access across the aortic valve is technically easier if you use the physiological way. You have a lower damage risk of narrow or kinked aorta, iliac, and femoral access vessels. You have a nearly unlimited access profile, and the stent grafts, especially for the aortic arch, are quite big. So the access profile is unlimited. You have a shorter approach to the target and a better device control due to the straight orientation. You can fix it better, and the deployment is easier. Also, the access to the supraaortal side branches is technically easier, and you can stabilize it easier against the systolic jet because you can pull on the stent graft instead of pushing. And the availability of cardiac units is good, so vascular and cardiac surgeons are working together. You can use the transcardiac access not only for the stent graft deployment, but also for through and through wire access for the retrograde approach, and of course for introduction of the main stent graft or for branch vessel access. The Transseptal and the Transapical Access is well established for TAVI, but not yet for TIVAR in the ascending aorta, the arch, or the supraaortal branches. But in anatomy like this might be a solution. But the problem is that the influence on the hemodynamics during transcardiac instrumentation with large stent grafts is not investigated yet. We investigated transseptal and transapical access in a porcine model. We introduced the wire from the femoral vein to the right atrium, then the interatrial septum was punctured. The guide wire was outsided via the mitral valve and the aortic valve through the femoral artery, so we had a wire right through the heart. Here you see the pigtail catheter in the aortic valve position, and in case of difficult puncture of the interatrial septum, we introduced an EPU catheter, and then the sheath could be positioned into the left atrium. Here you see the guide wire, the through and through guide wire forming a loop in the left ventricle. And if you pull on both ends, you have a straight route through the heart and you can position your sheath. This is one example of our PICS with the sheath in just distally to the aortic valve. The three white arrowheads demark the vena cava, and the white arrowhead at the top demarks the top of the sheath just distally to the aortic valve. The transapical access is routinely used in cardiac surgery. Here we have one of our patients where we introduced the stent graft in the ascending aorta via the transapical access, where it could successfully be implanted. The aim of the study was to evaluate the hemodynamic parameters during transcardiac access routes. There might be limitations due to hemodynamic collapse due to mitral and aortic valve regurgitation. Also, a problem might be myocardial and cerebral perfusion deficit. Therefore, we evaluated also myocardial and cerebral perfusion using fluorescent microspheres. We investigated 3 study groups. First one was transeptal access, then transapical access was the second group, and for control we used the retrograde approach. We used a short stent graft adapted for our pigs, and here you see our measurement protocol. First, we measured with the guide wire in situ. Next measurement point was with the sheath in situ. Then after sheath retraction was the next point, and finally after stent graft deployment. We measured hemodynamic parameters using Swan-Ganz catheter and Pico catheter, and we used transit time flow measurement of the carotid artery, and for myocardial and cerebral perfusion we injected Fluorescent Microspheres, which is a gold standard for tissue perfusion in animals. Here are our results. The stent graft could be placed in all animals in all study groups in the ascending aorta. Heart rate was stable in all pigs in all groups throughout the whole experiment. The cardiac output decreased a little bit in the Transseptal group, especially during the sheath deployment through the valves. Also, the mean arterial pressure decreased during measurement point T2. Pulmonary vascular resistance increased significantly during transseptal and transapical access. And if you see here the ratio between mean pulmonary arterial pressure and mean arterial pressure, you get an idea about the mitral and aortic valve insufficiency, which was highest during sheath deployment through the aortic valve. But it recovered immediately after sheath retraction, and at the study endpoint, we had no difference between the three groups. Myocardial and cerebral perfusion were measured here. You can see that Transseptal and retrograde approach had no limitation of myocardial perfusion. It seemed to increase, but it was due to the blood loss in those two groups. The blood loss was higher than in the transapical group, and we had to infuse saline solution. Therefore, the viscosity was a little bit lower, so the myocardial perfusion seemed to increase, while it was stable in the transapical group. Cerebral perfusion decreased a little bit in the transapical group. We think that's due to the fixation along the sheath. So we don't have a three-dimensional contraction, only a two-dimensional contraction. So that might be the reason for the decrease in the transapical group. If you have a look at the operating time, it was shortest in the transapical group, which was technically easier than the other approaches. Transfemoral access was most difficult. You see also the deployment time was easiest in the transapical group. We think that antegrade transseptal and transapical stent graft deployment in the ascending aorta is feasible in an animal model, and the antegrade transcardiac access shoots might be a useful treatment option for selective patients unfit for surgery. But there are some limitations. Current available stent grafts do not meet the requirements. The graft design is made for retrograde delivery, so we have done customized stent grafts so far. The access to the descending aorta is also limited, and it requires careful case and graft selection, so further studies are required. Actually, we perform a percutaneous transapical approach in a pig model for delivery of a fenestrated aortic arch stent graft, which could be successfully performed. Here you see the sheath right through the heart. And this is our branched arch device designed for our pigs. And after sheath retraction, we can use a special design closure device. Thank you very much for your attention.
Congratulations for a very sophisticated experimental study, and obviously in a very sensitive animal model to operate on pigs with and going transapically. I could imagine it's very difficult because they're very sensitive to any hard touching. What do you think? I mean, I don't agree with the indication in terms of type A dissection, what you said at the beginning, because when you operate on type A's, you know that the tissue is extremely fragile once the integrity of the wall is lost. So probably most stent grafts cannot cope with that issue and make things worse. But anyways, any questions from the floor? Bradley?
That is a great study, and it's interesting. I too agree that the transapical approach would be ideal for ascending and arch pathology because of control and access issues are eliminated. I question whether the stent graft companies will buy into that because it would take control of these devices out of the hands of the numerous cardiologists or vascular surgeons and put it into our hands, and we're in the smallest group. So it's not really a question, it's just a something to think about. But I think that it offers us the best control. And most of us that do TA work with transcatheter valves realize that it's a pretty straightforward, short procedure, and you get real comfortable with handling the apex.
Yeah, thanks again for a very interesting study. So it's a